Hi, everyone. I just wanted to welcome you to the Learning Collaborative for September 2018. Today, we're going to present two vignettes related to surgical therapy for epilepsy. We're not planning on covering the entire scope of surgical therapies, but we hope this gives you a little window to the field. Okay. So the objectives for today are to understand therapy options for patients with refractory epilepsy. We're going to talk a little bit about epilepsy surgery in terms of the indications and the evaluation process. And then Renat Jonas is going to talk about the vagus nerve stimulation indications and its efficacy. So first, we're going to start with a male infant. And at 2 to 3 weeks of age, developed seizures. His mother was very descriptive in saying that the eyes would move in an arc-like fashion. She actually used the word rainbow from the right side to the left, and then both arms would elevate, and these would occur in clusters. She then presented to care at 6 weeks. She had expressed it, but it was probably not necessarily recognized initially. Presented to care at 6 weeks to an outside hospital. And there that they saw the EEG showed bursts of polyspikes. And also, they seemed to be a little bit more in the right temporal regions. There was an asymmetry. We'll show you something that looked like his. And then he was placed on several medications without improvement. Levetiracetam was tried. Pyridoxine, which is vitamin B6, is often used when there's a challenging epilepsy in the neonatal or early infancy period. And then phenobarbital. This is the EEG when he came here, when he was 8 weeks. What was reported to us is when he first presented to the outside hospital, what they saw, and I think Renat can maybe point for us, is that in between these very tall polyspike bursts, what they saw was very little activity in between the bursts, something we refer to as almost a burst suppression-like pattern. And at that time, they were very worried about an early infantile epilepsy, one that can be very intractable, very, very hard to treat. And when he got here, it had morphed a little bit, changed a little bit, so that although it was very bursting in quality and somewhat periodic, there was more activity in those interbursts.
So I think that one thing we learned, so this kind of a pattern, sometimes it's called Ohtahara syndrome, right?
Or early infantile epileptic encephalopathy.
But if you kind of look in the older books, that's what you're going to hear. And many times it is due to some kind of probably more bad epilepsy.
Definitely.
So we don't think about good prognosis initially when we see this kind of an EEG.
And I don't know if we want to go back. It's hard to say on this one, but I had mentioned in the previous slide that maybe it's a little more right side. So when you're looking at the EEG, the top of the screen is left side of brain. Then we look in the middle, which are those two channels in the middle. And then on the bottom, those bottom 8 lines are the right side of the brain. You get a sense that maybe it's a little bit more towards the bottom than the top.
Yeah, maybe.
I would have been a little hesitant with this slide alone. Okay. So then at 2 months is when he actually came here to the Epilepsy Center for further management and was admitted to our inpatient unit. The EEG at that point, we actually saw some spasms. So somewhat very similar to infantile spasms where the arms would come up and there was an eye movement associated with it. And we saw that it was a little more right-sided. He had an MRI at the outside hospital. I'll show you that. It was suggestive of right parietal polymicrogyria, which are basically little tiny gyri all bunched up together, so an abnormal development of brain. And here we decided to start him on the ketogenic diet and clobazam. Now you might say, well, you just told me it looked like infantile spasms, isn't ACTH or vigabatrin the usual way that one would go? And part of the reason we chose not to go there just yet is he really was evolving from that early infantile epileptic encephalopathy, Ohtahara, as Dr. Jonas was talking about, maybe emerging into classic infantile spasms. And for Ohtahara, ketogenic diet is one of the things that might be useful. So because he hadn't fully evolved, we didn't necessarily go that route just yet. This is what his EEG looked like when he was having a seizure. So when he would actually have this eye rolling and the arm elevation, you see this very tall, slow wave, maybe with some intermixed spikes. When it's this tall, it's hard to tell sometimes. And then you can see right after it gets a little flatter. And I think what Renat's trying to show you is that is maybe a little bit more on the right. There's a little bit of this low voltage, fast activity, really teeny weeny stuff. Maybe suggesting more right-sided.
And I think that we had the EEG before we had the MRI, and we thought that we probably there's going to be something structural just based on.
Exactly. I think we didn't
Some
have a
hints
copy of
that
the
we had.
DVD at that point. And when he wasn't having a seizure, what you can see is at the bottom of the screen, again, right side of the brain, you really see many more polyspikes over there than on the top of the screen where it's quite clear. So again, saying, maybe there's something happening there on the right side. When you get an MRI in a baby this small, it can be really hard to see things such as cortical malformation strokes, pretty easy to see. But malformations are hard. He had a very good quality study. He was just young. But you might be able to appreciate a little difference. So on the left side of the brain, you can see there are all these little gyri. They're pretty easy to follow the lines and trace them. You could actually draw a pencil and trace them. And then in the purple arrow, you see it's much more blurred. And that probably represents an area of cortical malformation of the right parietal region. So what happened between 2 months and a year? So he did actually pretty well. He had very few seizures, at least clinically. EEG got much, much better. But at 1 year of age, he really started to have a lot more seizures, and they were much more noticeable and upsetting to the parents. So he developed a lot of focal seizures. He would stare, he would get eye deviation. Could be either side, but usually right, or he would just get right eye twitching. And then these may then generalize, and he would get stiff all over. It would actually even affect his breathing. His motor and language skills were impaired. So when he got to 18 months, he started sitting and crawling, but he wasn't walking. At 1 year, he was just learning to sit. So he was a little delayed. And we had referred him for a surgical evaluation at 3 months, but it was decided because he was doing so well to actually wait and see how he would do around a year of age before they might do the more extensive surgical workup. Actually, see if Dr. Jonas wants to comment about why that often is done. Why would you actually wait instead of doing it right at 3 months? She's the surgical expert.
So I think there's probably pros and cons. Doing the surgery at a very young age has much higher risks, surgical risks, including bleeding, and so on. So if the surgeon could wait, so if the patient is relatively stable and the surgeon can wait, we prefer to do it a little bit later. The downside is that if the patient, let's say, continues to have seizures and we are waiting and waiting, we might miss some opportunity for normal development. So we know that if we have frequent seizures, the child might regress or plateau in their development. So we kind of risk that important window. We know that really the first year of life is the year probably of most development,
Absolutely.
first or second year of life. And so I think that because he was probably stable and didn't have seizures, they waited.
Right. And some kids with cortical malformations can do amazingly well.
They can. The downside would be that if he starts seizing at 5 years of age and now we have to go at that age to do surgery, we might cause a little bit more deficits because the plasticity of the brain is not anymore as brisk. And for instance, something very interesting, we could actually do surgeries on the left hemisphere where our language is until age of 5 years, and the child would continue speaking, so the right hemisphere will pick up the language area. On the other hand, after this age, it will not happen anymore.
Right.
So we would not be able to do any more surgeries in this area.
So what are the predictors of intractability? Because that's really the major motivation to referral. So there was a lack of response for this little guy in the first year of treatment.
So it's actually interesting. It's lack of response for the first anti-epileptic drug.
Right.
So even if you fail one drug, that's already a predictor for intractability. I'll hear what you say.
She got ahead of me. High initial seizure frequency. So this little boy had lots of seizures in the early parts of his life. He had a very early age of onset that places him at high risk. use of more than 2 anticonvulsants without effectiveness, that would be him. He has a remote symptomatic etiology, not necessarily unless you consider cortical, would you consider cortical malformation remote symptomatic?
Maybe.
Yeah, maybe.
So would you want to explain what it means? A remote symptomatic etiology.
So basically it means that you have an epilepsy related to some abnormality earlier before the onset of epilepsy. So for example, it could have been a stroke that happened when he was first born, or in this case, it was a cortical malformation.
There's some kind of brain damage.
Or brain, an abnormal MRI, which is one of the reasons for symptomatic etiology. I could not say he was mentally retarded, but I would say that he clearly was developmentally delayed, globally delayed. And infantile spasms in particular are a risk factor, as would be periods of status epilepticus. It's just deciding. So who is the optimal candidate for epilepsy surgery? So obviously you don't want to do this unless somebody's poorly controlled after at least 2 new generation seizure medicines. Has a well-defined focus of seizure onset. We think in this case, I mentioned that it is subtle, but as he matures, they can do more imaging, and there are fancier ways to get a look at this area.
And I have to say that his focus seems to be posteriorly.
The EEG fits actually with the MRI.
Yes, the EEG fits with the MRI, and doing a posterior, more occipital parietal region surgery and removing that area will cause probably less deficits than if you, for instance, have to do it in the frontal region where you might cause hemiparesis. So he might lose his visual field on one side, or
so it depends. That also matters. Where is it? Isn't it in an eloquent area? Because with the cortical malformations in particular, they tend to retain some of the function despite the abnormality, as opposed to a stroke. When you have an injury, you really are going to have to move that function. So probably has an MRI that's abnormal here. And then the epileptogenic zone we've already talked about is functionally silent. So is it in an area that's really going to be critical for language or movement or something like that? Does a neurological deficit already exist? So you already have a hemiparesis on that side. So are you going to really make it worse by doing the resection? Or if somebody's already blind, and so if we have to take out a portion of the occipital lobe, it's probably going to be okay.
And I think that sometimes at age 2 or 3 months, it's really hard to see mild hemiparesis.
Very hard.
But it starts to develop. He definitely sometimes you don't see it immediately, but at 6, 7 months, you start seeing that the baby is reaching more with one hand compared to the other, has early handiness. And it would make it easier for the surgeon kind of to decide to go along and take that area out.
And obviously, the younger the patient, the better the outcome. I just put this here because it's important to remember that sometimes we wait too long, and so people think that surgery is really the worst possible thing that could happen to a child. When actually, if you act at the right time for the right reasons, it could be the best thing with the best outcome. And so waiting until 20 years, we're really not doing a favor to these children or their families.
Right. I think that the next case will illustrate this kind of a case.
Yep.
Okay. Anything that you'd like to give?
I think, this is a nice transition to the next case. So we talked about a case where there was pretty clear indications for surgery. The likelihood is if we really are able to isolate the seizures to that lesion, probably will have a good outcome and hopefully will not actually make him any worse. Sometimes, though, we are in the same situation of a case that's refractory, is not responsive to treatment, and we want to do something more, and then what can we do if we can't take out that area because either there are multiple foci or it's in the wrong area?
So I'm going to talk about a little bit of a different case. So this is a young man. He's 24 years old. I probably know him now for the last probably 8 years, 7, 8 years. He has long-standing epilepsy that started at the age of 5 years, and he has also mild to moderate intellectual disability. He is an immigrant that came to the United States when I first saw him, and at that time he had a history of having a few different seizure types. So one of them presented with staring. He had from time to time his head deviated to the right, and sometimes he would become pale. With some of the events, his eyes were blinking, with some he was moaning, with some he had urinary incontinence, and they were usually very brief. The longest one would be 20 to 30 seconds, but most of them lasted from 5 to 10 seconds. And with most of them, if he would be, for instance, standing or sitting, he would not lose his tone. He would just have this kind of a behavioral arrest with the staring. He had also more generalized, the typical tonic-clonic seizures where he would drop and shake. And then at nighttime, he had more what we call kind of asymmetric tonic seizures, where he would have a little bit of posturing of his extremities. Sometimes it would be very mild. He would just have eye opening and a little bit of posturing. That's it. And these tonic seizures were really missed because some of them were so subtle that the parents did not even pay attention. Even so, somebody always sleeps with him in the same bed. So like I said, it started at the age of 5 years. They happen between daily to weekly. And when he presented here to the US, we repeated some of the workup. We had the MRI at a younger age and then a repeat MRI just recently. And it's a 3 Tesla MRI, so it's what we now have as the best MRI. There is in some other institution a 7 Tesla MRI that is even with better resolution. But the MRI was entirely normal. There was nothing structural there. He had multiple genetic and metabolic testing. Everything was negative. So also the testing, because he's also intellectually disabled. And video EEG, he was here for 48 hours. And this is kind of a summary of multiple of his EEGs. Initially, we had about 30 seizures a day. He had focal.
So can I ask you a question? So initially you said daily to weekly. So at the start, was that on medicine? He had 10 to 30 a day? Or were they some of those so silent the family wasn't aware he was even seizing?
So when he came to us, he was on 2 medications. He was on carbamazepine and valproic acid. And yes, some of them, or most of them, the parents even don't notice because they're so subtle. And especially the nighttime, they see less. Yeah. He had clear left central temporal spikes and polyspiking waves. In sleep, it looked much more generalized. Then he had also something that we call generalized paroxysmal fast activity, which is kind of a marker of maybe there is something structural going on in that area. And then he had mild diffuse slowing of the background, which would indicate some kind of an encephalopathic pattern. And on top of that, also had just more slowing on his left hemisphere. And the left hemispheric slowing was more pronounced after the seizure. So it might have been due to just a post-ictal state. And this is an example of how his EEG looked during wakefulness. And like Lori said, so all the odd numbers, they're on the left side. The even numbers are on the right side. And we see quite frequent, especially in the mid-temporal area, some polyspikes and some wave and some spike and wave. And that's kind of typical for him to have during wakefulness. It's maybe also at times something disorganized on the right side.
And I forgot, you told me he was intellectually disabled. Is he verbal?
He is verbal, but minimally. But he does speak.
So I just brought that up because so much of the discharges were on the left.
Right.
And there's slowing in the left, which makes me think there's a lot of left hemispheric dysfunction for
Right.
this young man.
Right.
Yeah.
And I have to say that initially I actually thought that he's not verbal at all because he never said anything in clinic. However, the family said that he does speak. And nowadays that I know him for many, many years, I did hear quite a lot of speech. His sleep looks much more generalized. So if you see this blackness here, this is what we call the paroxysmal fast activity. It's clearly seen in both hemispheres. And then there's this generalized polyspike and slow waves, some polyspike and slow waves, which are quite frequent in sleep.
And that was a seizure, I would assume?
So some of them are very hard to say because he might not have anything with it.
Mm-hmm.
And then do we say that it has the criteria for electrographic seizures? And some of them would have maybe eye opening or a little bit of tensing.
Mm-hmm.
So some of them were clearer than others.
Sure.
And that would be kind of a typical seizures. where we see that on the left side, again, in this midtemporal region, there's a spike in wave that then evolves into what we call a little bit of a decrement or decrease in activity that is relatively generalized with overlying fast activity and muscle artifacts. So that's kind of typical how a tonic seizure would look like.
Absolutely.
But clearly starts on the left side. Even so, this area looks very generalized. And I just put kind of his medication history over the years. So when he came, he was on this carbamazepine and valproic acid, and clearly had a lot of seizures. We changed to oxcarbazepine and valproic acid. And I have to say that since he was started on oxcarbazepine, he never had again a generalized tonic-clonic seizure. So he continues to have the staring spells and behavioral arrest, the short ones, and he continues to have some of the tonic seizures at night, but never anymore a generalized seizure. At one point, he had a lot of vomiting, and we thought it may be related to the valproic acid, so it was changed. We added it to pyruvate. Later on, the levetiracetam that actually caused the paradoxical increase in seizure. He was then on phenytoin, which we don't like to start children on because of the side effect profile. And he developed quite marked gum hypertrophy, as well as anorexia, and lost quite a lot of weight. So we changed it to rufinamide with the oxcarbazepine, and somehow, I don't know, I'm leaving him all the time on the oxcarbazepine just because I believe that that's what took away his generalized tonic-clonic seizure, but he might not need it. I don't even know. With the rufinamide, it's known to be good for Lennox-Gastaut syndrome and children who have atonic seizures and sometimes tonic seizures, so I thought maybe it would be helpful. He lost a lot of weight with it even more, so we had to stop it. We added the clobazam, which he actually did quite well with it. His mood actually improved on it, which was interesting. But still, when we brought him, and the family thought that his seizures are much better, but when we brought him for video EEG monitoring, he still have quite a lot of seizures. So we added the perampanel at night. And the last step that was done was adding a fourth medication. So now he's on oxcarbazepine, clobazam, perampanel, and lacosamide. And when you get to that point, you're very confused because you don't know anymore what is actually helping and what is not helping.
You just keep layering and layering.
Yes. So about 8 years ago, when I met him and I saw his first EEG, I talked with the family about surgical evaluation. He's clearly very EEG, very left-sided. However, the MRI is negative. They, of course, didn't even want to hear about it. We talked about it probably every year until he's now 24. We brought it again, and they said there's no way they're going to go to a resective surgery. Now, this boy, because his MRI is negative, most likely would need to have quite an extensive surgical workup, which would include intracranial EEG. That might be kind of a long process.
It means when you put like these strips or grids on the surface of the brain. So you have to actually do a neurosurgery just to do the EEG part, although it's pretty minor.
The other thing that is not clear, where is his language? So is his language still on the left side? And if it is on the left side, and it seems that his seizures are coming from the maybe temporal region, some of them look a little bit more frontal with this tonic seizures that he has, are we going to cause any deficits to his language? So you need to have quite a lot of tests for that, including maybe a WADA test, which is quite invasive, maybe a functional MRI. Or is it the kid that has something there that started so early that his language actually transferred and his language is on the right side?
Sure.
Now, his seizure started at 5 years of age, so I believe that his language is probably still on the left. So that would be a kid that it's going to be really very hard to resect anything. We know that the success rate of surgeries that don't have a lesion or non-lesional resections, the seizure freedom is much lower. So he's not an excellent candidate, and the family really was not very interested. Should I put him on another medication? Lori, is there anything new in the world that I haven't tried? What about cannabidiol oil? Maybe.
So
Maybe put it there.
that'd be another seizure medicine. You know, soon we're going to be having that emerging on the market for kids with Lennox-Gastaut and Dravet. So that is going to be a new seizure medicine. One would say, you know, if he was not an oral feeder, it might be a little bit harder if he's taking by mouth, but ketogenic diet would be one.
Okay, so
And we've talked about that in I think one of the most recent learning collaboratives, we talked about that. We talked about he's maybe not a great surgical candidate and the family's opposed. So the next thing has to be neurostimulation.
Right. So I think the diet we showed before, if you fail 2 medication, the chances that you're going to be seizure-free with 3, 4, 5, 6, 7, 8 medication is almost zero. Resective surgery, Lori's little kid was a great candidate. This kid is not as great candidate. Ketogenic diet in this age group is very hard if you don't have a G-tube.
Yeah, let's
right?
use a tube feeder.
So we're going to the implantable. So we have nowadays a few options. Until maybe 5 to 10 years ago, we just had a vagal nerve stimulator. Now we have 2 other devices to use. One is called RNS, or responsive neurostimulation, and we're not going to talk about it today. And the other one is DBS, which is deep brain stimulation, which is used for movement disorders like Parkinson. These 2, the RNS and DBS, are a little bit more invasive because you have to implant electrodes inside the brain. The VNS, actually, we don't implant anything intracranially. So who would be a good VNS candidate? So somebody who is refractory to medication, you tried multiple medication and you did not succeed, that he's not a surgical candidate, and you might not be a surgical candidate because you have either generalized or seizures that come from both sides of the brain and you cannot just cut so many areas, that you have a seizure focus that cannot be removed without a substantial deficit, or you already had an epilepsy surgery and you failed it and you still have seizures. For the ones that the ketogenic diet is not an option, and it's actually a very good option for kids or adults with epilepsy who also have comorbid depression and behavioral difficulties, because we know that the VNS has positive effect on it. So what is the VNS? You said you have something that is to show a device.
I might.
Oh, yeah.
So this is an older one. This is an older model. The older models were larger. The newer models are about 2/3 the size of the one that I'm going to show you here. So there are these pretty flat, and this one's the larger one.
Yeah, now they're maybe half size.
I'd say about 2/3. And what happens is they get implanted.
They have a wire.
They get implanted on the left side.
Yeah, we got pictures that we're going
You're
to
going to
show.
show?
Yeah.
So she'll show you more. But this is a little larger. Oh, this is the Aspire.
What is the Aspire?
So this is a newer model, but it's just bigger because it has a lot more functionality to it.
So it has few parts. It has the device itself that generates the impulses. It has a wire that connects itself to the vagal nerve. We have a magnet, which the patient has the ability to actually induce more impulses and give themselves more voltage if they have seizures. And we have the doctor who has an iPad-like device that can change different parameters in the VNS. Now, over 33,000 kids, I just took it from the VNS website because it, of course, changes all the time. So over 33,000 kids were already implanted with the VNS. And just recently, this year, it was approved for children up to 4 years of age. Until recently, it was just 12 years and above, but now it's for 4 years. I have to say that we have very young children, infants even, that get the VNS implanted. The only thing you really need to have, you need to have enough fat pad. So subcutaneous tissue that can cover the VNS when you kind of implant it. And we're not really sure what is the mechanism of action. We know that it affects kind of higher brain area and somehow is involved in a brain area that are involved in inhibition of propagation of seizures. and some changes in blood flow, but what exactly it does, we don't know, and it promotes some desynchronization. If you remember what we learned in our one of the first talks that we gave, is that to have a seizure, you need a really synchronized brain activity, and that kind of causes a desynchronization. Between different studies, it can reduce seizures by, so when we say seizure reduction, we don't always talk about seizure freedom. And that's the same with medication. You don't look at seizure freedom, you look at 50% reduction in seizures.
So this is about the same as if we tried another seizure medicine.
And so that's about the same.
Same odds of making him 50% better.
Right, about 40 to 60% better.
Mm-hmm.
So, and that's how it looks like. So like Lori said, you implant it on the left side of your upper chest, and that is the generator. And then it has a little wire that is implanted, of course, subcutaneously, and it connects to the vagal nerve. Here you see it nicely. That's a nice live picture. And this pulse generator works all the time, so it's not an on-demand. So compared to if you think about a pacemaker, right, that the pacemaker just starts sending impulses when you become very bradycardic. Here it sends it all the time, but we have the ability to change some of the parameters. So typically you would have 30 seconds that the VNS is working and sending impulses, and then you have about 3 to 5 minutes when it's quiet, and then another 30 seconds when it sends impulses. So we can change the strength of the impulses, how much voltage we would like to submit. We can change the width of the pulse, and we can change the cycling, so we can make it much faster. So we can say we would like it to send impulses every, to work for 17 seconds or 18 seconds, every 1 minute or 1.5 minutes, and so on. So this is kind of the things that we can change.
It does have the on-demand feature, though. So
the new one, right?
Oh, well, in the sense that, especially if it's a patient that there's a warning sign before the seizure starts.
Right.
So an adult who maybe is a little bit more aware of their body might feel it coming on. They can actually activate it, and if they can't, they can instruct somebody to activate it for them.
So you can use this magnet. So that's what the magnet does, right?
So it has both features. It's cycling all the time, and then so school nurses, for example, might be having this, or a paraprofessional might have this, and they're taught in how to be able to swipe the VNS.
So you swipe the VNS, like you said, you can swipe it either when you feel that you're going to have a seizure, but you can also swipe it during a seizure.
Mm-hmm.
And it actually shows that it reduces both the seizure length and the postictal state. So every family actually uses it when you have a seizure. They swipe to give an extra impulse. There is no new VNSs that can give you extra impulses depending on your heart rate. We know that with some seizures, usually you can have tachycardia before the seizure, and when the vagal nerve stimulators would detect this tachycardia, they would give extra impulses.
Mm-hmm.
And we have other newer versions of VNS that we actually have now 2 new patients that have it. You can change the parameters, so you can have some hours during the day more impulses than other times. For instance, my patient, if he mostly has nighttime seizures, we can have stronger impulses during the night than during the day.
Right.
The interesting thing with the vagal nerve stimulators is that we see that the efficacy actually increases with the years. So if in the beginning we only had about 23% of patients with 50% seizure reduction, over 3 years it doubles. So it is really important to explain to the patient this long-term effect. And what are the side effects? The side effects are relatively minimal compared to a lot of the side effects that we have with our medication. Probably the things that bother the patient mostly is cough. And if you think that the device is connected to the vagal nerve, so you can understand, of course, that there is going to be some itchiness, some cough, some voice alternation. They become kind of hoarse or dysphonic during the VNS. It sometimes can cause also pain or paresthesias or headaches, and it can worsen obstructive sleep apnea. It's not written here, but this is something that can happen. it's quite interesting because you can hear the patient. When the patient talks to you, you can actually hear when the vagal nerve stimulator is working, because the voice kind of becomes a little bit deeper.
Mhm.
Right? So what is good about the vagal nerve stimulation? So we have evidence, good evidence, that it reduces seizures. Maybe not seizure-free, but it reduces seizures. It doesn't have any interaction with other medication compared to a lot of our other medication that do interact with each other. It has a good side effect profile.
I think most importantly is that most of our seizure medicines make people feel sleepy,
Right.
or maybe slower in processing information. And here we don't really think about any cognitive side effects. So that's really, really
Yeah. Not only that,
bonus.
it's probably improvement.
Yeah.
So, of course, if we have somebody on the vagal nerve stimulator, we can maybe decrease some of their medication. But independent of that, even if you're not, so the vagal nerve stimulator is, for instance, used for depression, right? It has an indication for depression. So we know that it improves your mood. It really improves behavior of children with Lennox-Gastaut syndrome. It improves energy level, and it gives you some control. So it kind of decreases the patient's fear and anxiety of seizures, because they have the magnet and they kind of feel, oh, I'm going to have a seizure, I can swipe it. So it gives them some sense of control over their epilepsy. So I think this is a device to think about.
Absolutely. Well, I'd like to thank you for joining this session, and we look forward to seeing you again next month.